All right, well, it's a couple after 6, and we're kind of getting up into the double digits of attendees. So if it's all right, I think what I'll do is I'll go ahead and kick things off. Thank you, everybody, for joining us on this virtual community lecture series, something that we've been doing virtually now since COVID hit, and we've had the benefit of some great expertise, both from Newport Hospital and from the Lifespan system, and that tradition continues tonight. So for those of you that don't know me, I'm Jeff Gaines. I'm the Chief Medical Officer at Newport Hospital, and I'm an emergency physician by background. And so I will just be doing a quick intro to our guest speaker, and then I'll do some of the logistics. But just to let everyone know, if you haven't been on one of the community lectures like this before, it's set up as a Zoom webinar, which means that right now you'll be muted and you won't be able to unmute yourself. So that means if you have questions or comments or compliments or things of that sort, there's 2 ways that you can interact. You can click on the bottom if you're on a computer. I think on an iPad, it's the same. There's a Q&A button with 2 little talk bubbles. You can click that and put in questions. You can also use the chat box function, just like you would on other media pages. So either one that you'd like. They both work a little differently, but for all intents and purposes, they'll be the same for this, and I'll be keeping track of them. So whichever is easier. So please put any questions, comments, topics you'd like to hear more about, things of that sort in the Q&A or the chat, and I will moderate those. And without much further ado, I'd like to make sure we have plenty of time for Q&A because we are very fortunate to have Dr. Karen Tashima on the line. If you haven't seen her on the news, if you haven't read about her work, then I would be a bit surprised because it's been out there quite a bit, especially with some recent developments in the Novavax trial, which I'm sure we'll hear quite a bit about. But very much like a lot of our community lecture series speakers, it always amazes me the talent and the pedigree that people within Lifespan and that we have the luxury of connecting with really have. So Dr. Tashima did her medical school at Columbia, and then she did her residency in internal medicine at New York Presbyterian, and then continued on to do infectious disease at MGH, and then moved to Brown. I won't tell how many years ago, but you can do the math, but it was 1995, I believe. So she's been here for a little while and doing a ton of things, both at Brown and at Lifespan. She is a professor of infectious disease at the Warren Alpert Medical School at Brown University, and also is the director of clinical trials at the Immunology Center. She does a lot of work and has been the director of the HIV care at the Miriam. She chairs the Miriam's Institutional Review Board, which is important for researchers in terms of structuring their research projects. She's been a mentor. She's been a teacher in terms of being a director in the Infectious Disease Fellowship here. So she's had a lot of teaching roles, and obviously research is one of her main areas of interest. And then most recently, she's been working with the Department of Health here in Rhode Island on the vaccine task force, and doing some work on COVID-19, given all of her expertise in other viral illnesses. It sort of makes sense that she's one of our experts on COVID-19. And like I mentioned, she's been one of the primary investigators on a lot of studies in and around COVID, not the least of which are remdesivir, which is a treatment that we've offered. And Dr. Tashima and I connected early on in the pandemic when we had patients in Newport Hospital that we wanted to be able to offer the drug remdesivir to. At the time, Newport wasn't a site for the trial. And so Dr. Tashima was able to help us become that and also help us with moving patients up to the Miriam and Rhode Island Hospital where they could get those treatments even early on while they were still under trial. And she's also been instrumental in Lifespan, really being at the cutting edge of medical science in terms of COVID-19 treatment and vaccine, as well as other illnesses, of course. And most recently, the Novavax trial, which is one of the vaccines that you'll hear about for COVID-19. And so there's been some developments recently kind of hot off the press. So I won't steal her thunder. I'd like to turn it over to Dr. Tashima, but just from my heart, a huge thank you for taking some time to kind of go through some of the work that you've been doing lately here at Lifespan and at Brown. And then I'd love to open it up either during or after to questions. So encourage people to pop some questions in the chat or the Q&A, and do take advantage of this opportunity to have a world-renowned researcher, professor, knowledgeable source of things, infectious disease, vaccine, and otherwise at our disposal. So she is a great presenter. I've heard her speak quite a few times, most recently at our ethics committee, while we talked about the pros and cons of mandating COVID vaccines for healthcare workers, which was a stimulating conversation. So if time allows, we can wander down that path. But I will turn it over to Dr. Tashima. Thank you again so much for joining us.
Thank you. Thank you, Dr. Gaines. So we'll talk today about COVID-19 vaccines. And I know that many of you know a lot about COVID-19 vaccines. Some of you hopefully have received the vaccine, a vaccine. So I thought I would do a little bit of an update and, talk about what's been happening since the mass vaccination campaign started in Rhode Island, in Massachusetts, all over the US, and what has been the impact of vaccination. I'll also give a little update on side effects, what's going on for children, what's going on with the variants, a little bit about my thoughts about vaccine hesitancy, and the big question about when will we need booster shots. So, and I'm happy to take questions throughout. So Dr. Gaines can interrupt me anytime and let me know what your questions are. So we'll just to set the stage, this is a sort of a pictogram of the virus, and the red areas are what we consider the spike protein. So there's this spike protein covering the virus, and that's the basis for a lot of the vaccine work. So all of the vaccines that we have available are based on getting our immune system to recognize the spike protein and disable the virus at that point. So not letting the spike protein allow the virus to dock on our cells and thereby stopping further infection of our cells. So we know we have several vaccines available. The ones in bold are the ones available in the US, the Pfizer, Moderna, and the Janssen. So the Janssen is also called J&J vaccine or Janssen vaccine. I guess that's maybe the Belgian pronunciation. But the two, the Pfizer and Moderna that came out first, are the messenger RNA-based vaccines that require a lot of freezer time. And it's because the messenger RNA that encodes for the spike protein is very sensitive and degrades very rapidly. So keeping it in a deep freeze stabilizes it, and so we get the full effect of the vaccination. The DNA-based vaccines are AstraZeneca and Janssen, and then there are some protein-based vaccines, Novavax and Sanofi. And again, they're all based on getting this protein made in our bodies after the injection, and then our own immune system will recognize it as foreign and get rid of it. So, and stimulate the immune system to be prepared to get rid of the next time it encounters the virus. So, so none of these vaccines can actually give you COVID itself, and they're given, some of the vaccines are given with or without an adjuvant. So an adjuvant is another molecule that will stimulate the immune system to recognize whatever's been injected. So it's kind of an additive to just boost the effect. And we do know about the shingles vaccine, the Shingrix, is a vaccine that's made with an adjuvant. So we already have experience with that kind of technology. There are two other vaccines that are listed at the WHO as approved by the WHO. So WHO has approved the use of all of the ones listed here. In the US, we don't have AstraZeneca, but the WHO does recognize it. Novavax and Sanofi are too new, so they're not actually approved by either WHO or the FDA. So, but Sinopharm and Sinovac they took the virus itself and inactivated it, and injected it as a vaccine. So just this next slide shows a nice picture of one of our first vaccine recipients at Lifespan. This was in the lobby of, actually at Rhode Island Hospital. So in the Jerry House, and it was quite an exciting event on December 14. And so this kicked off the vaccination of as many employees as we could get in Lifespan. And, we all felt very glad to be participating, be the first to step up and show that it was safe and that we were willing to take the vaccine, and also to also protect the healthcare force so that we could provide care to the COVID patients. And then many non-employees were also received the vaccines through Lifespan, which was, such a great effort. And we also had high-risk allergy clinics because there was a concern that if you had an allergic reaction, we wanted to be ready to deal with that in the most medically appropriate way. So the messenger RNA vaccines that you've heard about, Pfizer and Moderna, I'll quickly go through. They had thousands of patients, participants in these studies, and the results showed that both vaccines were highly effective. You've heard numbers like 94 and 95% effective. And what that really meant was, these are the numbers, that 185 in the placebo arm in the Moderna study got COVID, but only 11 people in the vaccine arm got COVID. So that's where they crunched the numbers and find out that it was 94% effective. And it was similar no matter what the person's background was, whether they had obesity or other coexisting conditions, and similar for the Pfizer. The AstraZeneca and Janssen vaccines are in the same bucket. They are both made from adenovirus vectors that don't replicate in your body. So adenovirus is a common cold virus. There are many subtypes. And so the AstraZeneca vaccine uses a chimpanzee cold virus, and the Janssen vaccine uses a human cold virus. And so what they do is they put a little piece of the spike protein DNA into this adenovirus vector, and that is what the vaccine is based on. So here we also see that there were many thousands of people participating in these trials. These trials were conducted a little bit later in the fall of 2020, but showed about 70% efficacy, 70% effectiveness at preventing COVID illness, and a really high percentage at preventing serious illness and death. So this was the basis of the Janssen vaccine was granted an EUA by the FDA, and AstraZeneca was approved in other countries by the European Union. The protein-based vaccines that I'll talk about, these are similar to vaccines that have been developed and used to prevent hepatitis B, pertussis, which you might know as Tdap, where we give tetanus and pertussis together as a vaccine, and vaccines to prevent pneumococcal pneumonias and meningitis caused by meningococcal infection. So in a way, these vaccines are a little bit more standard because Novavax and Sanofi are using just the protein but adding an adjuvant to boost the immune system. So the Novavax recently presented data to us on the phase 3 study that we conducted here at the Miriam, and also at another site in Rhode Island, a standalone research site. And so the Novavax participants, there were 30,000, and this study showed 90% efficacy. So, and all of the cases that came about in the vaccine group, and there were only 14, all of those cases were very mild. So again, 100% protection against moderate or severe COVID in this trial. So that's great. And the other news was 93% protection against variants. So we've been all very concerned about variants because those have come about over the last 6 months. And so the Pfizer and Moderna studies didn't have to protect us against variants. We didn't have many variants at that time. So, but as time went on, we've had more and more variants. So the Sanofi trial, I wanted to do that trial here as well, but because it is the phase 3 study that needs to show how effective it is, it needs to show how effective it is against a placebo arm. And so I didn't feel that we would be able to enroll people in a placebo-controlled trial, that everyone is eligible to get a vaccine now, and I didn't think that that would be feasible for us to do here. So we're not doing it here at this site. What is the impact of the COVID-19 vaccination? So we want to know, we're in a really nice place right now. We have very few new cases. In Rhode Island, I heard one day there were only 30 new cases that day. And as you know, we've been dealing with hundreds, if not thousands of cases at some point in the last year. So this is a snapshot from the MMWR, which is a publication from the CDC. And what they're correlating is the introduction of the COVID vaccine and the and COVID illness. And I'll show you this slide and the next slide to show you the correlation and what we feel is the impact of the COVID vaccine program. So here, as you can see, these blue bars show, these blue lines show different age groups who, like this one, this solid line shows that shows people greater than 65 years of age who had gotten at least one dose. The next line, this dotted line, shows people greater than 65 who had gotten 2 doses of their vaccine. And then these other lines that come a little bit later show the lower age groups, 1 dose and then fully vaccinated among 50 to 64-year-olds. And then the bottom 2 lines show people 18 to 49. So everybody, we know that, we were going mainly by age in terms of vaccinations across the country. And so the younger people got their vaccines later. And the black bar shows overall, like the daily doses given. And we see that there was a steep incline upwards and then drop off in demand of the vaccine. But if you look at these 4 graphs show something different. We're looking here at the different age groups, but again, with these blue lines, but then on what we're really showing is COVID illness. So there was a lot of COVID illness in December, January, reaching a peak and then coming down over time. And then this one shows ED visits, so emergency room visits for the different age groups and how it was spiked up in January and then came down. This one shows admissions. So if somebody hits the emergency room, they have a chance of needing to be hospitalized. And so that's what this shows. And then these lines show deaths due to COVID. So what we can see here is that we have a nice decline in all of these cases of COVID, people having to come to the ER, people having to be hospitalized, and people dying of COVID. The black lines show the older age group relative to the younger age group, and again, showing a big decline in the amount of COVID illness and morbidity compared to the younger age groups. So we can see a really nice correlation between the times when between the time that we gave vaccines and these illness charts. So what is the situation worldwide? As you can see from this is a COVID World Vaccination Tracker that the New York Times picked up from another site. And you can see that the really dark countries are the countries that have the most vaccination doses administered to their people. So we can see that, the US and Canada, I think this is Greenland, China, Europe. So there are many countries that have, very high vaccination rates, but then many countries in Africa, particularly, and other areas that are really not getting the vaccine that we'd like them to get. So, this really poses a lot of, consideration about how should we how can we get the vaccine spread across the world more easily. Just to touch on an issue that people may have, that what do people do if they're vaccinated outside the US? So we do have CDC guidance on this. So they might have gotten an AstraZeneca vaccine, or they might have gotten a Sinopharm vaccine. What should they do when they come here? So the CDC says that if they got an FDA or WHO authorized vaccine, they don't need additional doses here. If they did not receive all the recommended doses, then they can get an authorized FDA authorized series here. So if they got 1 dose of AstraZeneca, then they could take 2 doses of Pfizer or Moderna, or they could take 1 dose of the Janssen. If they got a vaccine that's not even listed by the WHO, then again, they can get an FDA authorized series. So moving on to rare side effects. So I want to talk about some of these side effects. I think many of you know what happens when you get a shot, one of these COVID vaccines. You can get fever, headache, muscle ache, not feeling well, tenderness at the arm, but usually that goes away in a few days. So that's really well publicized. It's on the information that you get when you get your vaccine. What we also know is that we saw some cases of severe allergic reactions, and that came about very early in the EUA distribution of the vaccine. So it wasn't really seen in the clinical trials. But if the clinical trial only enrolled 40,000 people and there was a placebo arm, so maybe only 20 to 30,000 people got the vaccine, you might not pick up some of these rare events. So, but those rare events kind of perked up people's attention. One or two cases of anaphylaxis that happened. There were a couple of cases in Alaska, and we've got such a great information system. We find out right away that this happened. And so people quickly, decided that we should monitor people after their vaccination. And if somebody has had a severe reaction or anaphylaxis in the past, that they might want to even wait for 30 minutes. So it turns out that the rate of anaphylaxis or severe allergic reaction is pretty rare. I believe it's still only about 10 or 11 in a million doses given. So it's pretty rare. But if it happens with the first shot, then don't get the second shot. We also talk a little bit about COVID arm. So a really sore arm or red rash on the arm at the site of the injection. But that's considered to be okay. You can still get the second injection. It's not considered to be a serious allergic reaction. What did appear a little bit later with the Janssen vaccine that was being given here, after about 7 million doses, they discovered a few cases of severe blood clot that occurred in the brain, sometimes in the abdomen, and in association with a low platelet count. So platelets are one of your cells in the blood, and it helps your blood clot. And if it's very low, you could have bleeding. So it's this strange syndrome where there was clot plus there was a low platelet count, and it's felt to be an immune response that can occur rarely. It was mainly seen with AstraZeneca and with the Janssen, and we saw that around the world that there were cases of this happening after having received AstraZeneca. And so when it happened with the Janssen, they are in the same group of the adenovirus vector-based vaccines. So maybe that makes sense. So basically in this country, the Janssen distribution was halted for about 1 or 2 weeks. And there was a lot of investigation into the cases that had occurred. And basically, they were almost all in women less than 50 years of age. And so the recommendation, after a lot of consideration by the adult or the ACIP, which sets recommendations for immunizations, I think it's called the American College of Immunization Practices. They did go you go ahead and inform the person if they want to get the Janssen vaccine, or you can give them other options. They don't have to get the Janssen vaccine, and letting them know, giving them the information that this can occur in women less than 50. More recently, another event has appeared, and that is inflammation of the heart or inflammation of the tissue around the heart. This is called myocarditis or pericarditis, and it's being seen among younger people who are getting the Pfizer or Moderna vaccines, and mainly in boys or men. So this is mainly after the second dose, and continues to be a lot of investigation into it. There have been, there's going to be a meeting tomorrow as well about it. But the CDC continues to recommend the Pfizer or Moderna vaccine for anyone ages 12 and older. Or no, basically it's the Pfizer right now because we don't have approval for the Moderna vaccine at this age. But, and this is due to considerations of complications of COVID. So it's really the risk benefit ratio that this is a pretty rare event. And given the risk of severe complications from COVID, that the balance is in favor of continuing vaccination. So there's more to be seen for that issue. Here, going back to what was seen in the Janssen vaccine, you can see that there were a couple of cases, 3 cases among the 18 to 29-year-old group, 7 in the 30 to 39 group, and then they give you the rate, which was either 5 per million or 11 per million. So, very, very rare events. And so that led to, we need to give information to people who want to get this vaccine, and then they can make a decision whether they want to do that or get a different vaccine. So what about getting vaccines for children and adolescents? And so I know many of you who have children, young children, want to know what's going to be done here and when is a vaccine going to be available. So recently I heard a nice presentation that the risk of death due to COVID is low among kids, but there were greater than 300 deaths due to COVID in the US last year. And so it can be serious. And we know that 3.78 million infections have been documented among children in the US. So right now, among the new COVID cases, the rate among children is rising because the older populations have now gotten vaccinated. So that makes sense. But it turns out about 22% of new COVID cases right now are in children. The Pfizer vaccine has been authorized for ages 12 to 17, and there are studies that are ongoing for the Moderna and Novavax vaccines. So Moderna, they have cute names for their studies. One is called Teen Cove and one is called Kid Cove. The Teen Cove study gave some already put out into the public some information about how effective the Moderna vaccine is among kids. So this was 96% effective among 3,000 participants. And then Kid Cove is ongoing at 6 months to 12 to 11 years. And the Novavax study is also enrolling a couple of thousand children. Pfizer expects to get approval for ages 2 to 11 by September, and then maybe under 2 years of age by the end of the year. So we'll move on to variants and breakthrough cases. So what's interesting is that the vaccines are, either 70% or 95% effective, the ones that we have right now. So there is some expectation that there will be breakthrough cases. We don't expect to see a lot of cases result in hospitalization or death because the studies showed basically 100% protection against that. But as we know, the real world, we call it the real world when a vaccine or medication is widely used or can be prescribed. And so the real world is that there are some breakthrough cases. They did an analysis of about 10,000 cases of people getting COVID after vaccination. And a good quarter of them had asymptomatic infection. So they were just getting swabbed because they needed to get a swab. So a good quarter were asymptomatic. Many people had mild symptoms. And right now they've shifted their attention then to only breakthrough cases that occur that result in hospitalization or death. So that's going to be, the real world monitoring of any breakthrough cases. But the number of cases is very tiny compared to the number of doses of vaccine that have been given. And as we know, the rates of COVID have dropped dramatically. In addition, we're concerned about the variants. And here we have now the new WHO labels for the COVID-19 variants. We don't have to remember the B117 anymore. We can call it Alpha. But we have to now remember which one is which. So the UK variant that's called B.1.1.7, that's now the predominant virus here in the US, is called Alpha. The one from South Africa that we don't have much here is called Beta. And the one from Brazil, which was called P1, is now called Gamma. And the one from India that people are concerned about is called Delta. Then they have variants of interest. And so we don't hear too much about these variant viruses. But currently, our current vaccines are effective against the variants that we have seen here in the US. And this is a bar graph that shows over time which virus variants have become predominant. And so you can see here the B.1.1.7 accounts for something like 70% of current viruses in the US. And P1 and then the B.1.526, which B.1.526 is apparently from California, and the P1 was from Brazil. So right now that's what the picture looks like, and I'm glad that they're doing genetic testing so that we know what we have here. A couple of things that we don't know about, everybody's assuming that we're going to need booster shots. I hope it'll be a long time before we need booster shots. Right now, it looks like we're good for at least 6 months and probably longer. Maybe, maybe it'll be a year or 2 years, but we don't know exactly. So I think it's premature to say that we will need boosters. We don't know yet. And how are we going to know? So one thing that we do in clinical trials is we're taking people's blood and we're taking it at every 6-month intervals so we can measure how much antibodies in their blood. And we're also asking them to report any COVID infection that they know about. So if they got a COVID test and it was positive for SARS-CoV-2, they need to tell us. And then we ask them every 6 months too, whether they, and then we also, they keep an e-diary. So every day they have to report if they have a fever or if they have any symptoms that could be COVID. So, and if that happens, if it happens like 2 days in a row, I get an email and the rest of my study team gets an email that says, participant number 131 had some symptoms. And what we do is reach out to them and we have them come in for a COVID test. We also draw blood at the time. So we do an interim visit. So basically what we're doing is we're following people over time who have gotten the vaccine in our study, let's say the Novavax. We're following them, we're watching their antibodies. Are their antibodies staying elevated or are they coming down? Are they getting COVID during the rest of this study? And then we can correlate, we can understand what level of antibody is needed to protect somebody from getting COVID. So, and so that's really an important part of this. That's why we're continuing to follow people for 2 years. We want to know how long does their protection last. So I mentioned that there was a New England Journal article about looking at the Moderna vaccine recipients in the study and showing that they continue to have good levels of antibody. But that's only part of the story. We want to also know, are they getting COVID? So if we were to see an uptick in COVID infection among our vaccinated population, we would know, okay, the vaccine effect seems to be waning. Of course, we also need to keep an eye on what kind of infection are they getting? Are they getting a variant infection? And that might not be, easily prevented by that vaccine. So another thing that we don't know that much about, because the studies didn't really look for this, was, are we preventing asymptomatic infection? And so there is a big study that's going on right now, and I hope to be participating in it. It's going to be for ages 18 to 29, anybody who's not gotten a vaccine yet. And what we're going to ask them to do is get paid for swabbing their nose daily for 4 months. So we think this will be a fun study because they'll get paid for every swab that they do. But what we want them to do too is tell us, help us enroll their close contacts. And so our participants are either going to get a Moderna vaccine immediately or sometime in the next 4 months. And what we want to see is, are they getting asymptomatic infection? Does the Moderna vaccine prevent asymptomatic infection? does getting the Moderna vaccine prevent them from spreading it to others? So this will nail down, we think it all makes sense that the result will be what we think it's going to be, but we want to do the clinical trial to prove it. So the other problem are people who have immunocompromised health conditions. So they might be receiving chemotherapy, they might be receiving monoclonal antibodies for rheumatologic conditions, and so we have many people who are doing well or being treated for their underlying health condition that might, as a side effect, might cause them to be more susceptible to infection, and at the same time, because it's affecting their immune system, might make them less likely to have the good immune response that they need from the vaccine. So they might get a dose of vaccine, they might get 2 doses, and they might still not have good antibodies. They might not make antibodies. And so, do they need a 3rd dose? Do they need a different vaccine? So those kinds of studies are ongoing. We know that it's safe, or we don't think it's not safe to get the vaccine if you have an underlying immunologic problem. But the benefits might not be as great as in somebody who doesn't have an immunocompromised system. So fun little area to talk about is vaccine hesitancy. So we know that the demand for the vaccine has really dropped off everywhere. President Biden is really, has been pushing that, people really go and get the vaccine. We all want people to get the vaccine, but for a variety of reasons, people may still be on the fence about it. And I think a couple of things that we can help people with is telling them, we can tell them, look, I got it and it's fine. So many people have gotten it. And, we also think that the risk of COVID is worse than the risk from the vaccine. So let's talk about that. So I think it's really worth having conversations. I'm really fascinated by what people say. And sometimes they might just give you what you think is maybe an excuse, and that they just really don't want to get it. So, but what's sort of underneath that excuse? What are they saying? They might say, well, it was developed too fast. I'm scared. I don't know what's going to happen down the line. I want to wait and see. So there are a lot of things that people say, and I think it's worth going a little bit further into that conversation and trying to understand what the hesitancy is really about. I do want to give, I'm doing this lecture because I want to make sure that people have up-to-date information, and everybody's got busy lives. It can be hard to, be looking at information on the CDC website, but I do think the CDC website is fantastic. So we just try to distinguish myth from reality and encourage people to not believe some rumors that are going around. We also know that people who trust their providers, I've had people come into the office for a routine visit, and I ask them if they've gotten the COVID vaccine, and they say, well, what do you think? I'm here to ask you what I should do. So that's a perfect time to say, yeah, let's, you should get it, and let's help you do that. And then certain motivations. Some people everybody wants to get out and have a normal life again. Getting people to know that they will be able to take off their masks, go out to eat. They don't have to sequester at home anymore. That helps a lot of people feel that the time is right for them to get a vaccine. And then there's certain mandates. So some, universities are requiring vaccination, employers are requiring vaccination, or the person will have to wear the mask. So people, are really feeling pressure to go ahead and get the vaccine, and that ultimately, their employers may just require it. So I think that's really an interesting discussion to have. So I'll finally conclude here by saying, knowledge is power, information is liberating. Education is the premise of progress in every society and every family. So this was a quote from Kofi Annan. I looked up knowledge is power, and this is what I found. So I think, information is important. Good information is even better. So asking your trusted providers, reading reliable internet resources, continuing to stay informed because things are still moving in different directions. We don't know exactly how long the pandemic will be, whether we need boosters, what kind of variants will be around, what our case is going to go back up. So these are the things that occupy my thoughts. I think that we can continue to do good hand washing, and minimize any spread of respiratory viruses. I think that will be really important to continue. That was a good side effect of all of the COVID requirements. And get the vaccine for yourself. Encourage your friends, family, and acquaintances, anybody who hasn't gotten it. Even join a study to help us gain better information, because it does. Studies are difficult to do. They take time. And if we help a study get enrolled and get results from the study as quickly as possible, the better off we'll be. We'll have more reliable information and not just rely on opinion or small studies that might be misleading. But if we have large, well-designed studies that are done in a timely manner, then we'll have really good results. We'll have really good information. And I want to thank everyone for being on the call, and I'm happy to take any questions.
Awesome. Well, thank you so much for going through that. And I've been taking notes. I had about 100 questions before. Now I've narrowed it down to just a couple. So I'll hold on to mine because it looks like there's a few that are coming up. I don't know if you can see the Q&A box, but Edna typed in 2 questions, one of which, if you can see it, is for those that can't, 6 to 9 months after getting the vaccine and a decision hasn't been made regarding boosters, would it be a good idea to get your antibodies checked? That was her first question. If you want to handle that one first.
So, I mean, that's a great question. We don't know, though, what level of antibody is needed. It might make you and your doctor feel better, but I don't think it's necessary to do. I think that we have now people in clinical trials who've gone past the 6 to 9 month mark, and we haven't heard of a lot of COVID cases occurring in that group. So I don't think it's necessary at this time. And it says, please repeat the info on those who say they cannot get a shot due to health issues. So basically, if you have an underlying, there's really almost no reason not to get the vaccine. There's, any health condition you have, the only one that might give you pause against doing the Pfizer or Moderna could be, anaphylaxis, and then you could be observed for 30 minutes. So the only problem with underlying health issues is really the opposite, that you might not get the response that you are looking for. You might not be as protected against COVID if you have an underlying health condition where you're immunosuppressed, where your immune system is just not that healthy. And you would know that if you had recent chemotherapy, or if you are getting some, shots for rheumatoid arthritis, some of those medications can make your immune system a little bit low, and then might not get the benefit from the vaccine that we would hope for. So you'd still probably have to be a little careful getting out there in public.
Awesome. One of the questions I was going to ask you is, I know we talk a lot about efficacy, especially at the beginning when, should I get one that's 94% versus one that's 95%? But I remember doing a little bit of looking back in the day about flu vaccines, and their efficacy numbers are pretty terrible compared to COVID vaccines, but yet still are really helpful in preventing severe disease and things like that. So just curious, your thoughts on how much should we focus on efficacy of illness versus efficacy of severe disease? And should we kind of rethink that a little bit, especially as we're starting to look towards the fall and maybe another flu, season, if you will, if that's even a thing anymore, if flu is a going to be another seasonal illness and whether this one will be on top of it. But I'm just curious about the efficacy.
Right. I mean, the efficacy or how effective the vaccines were at preventing any COVID illness was pretty high. So between 70% for the Janssen vaccine and 95% for Pfizer and Moderna, they were all 100% at preventing hospitalization and death, so severe illness. So you might have a cold or mild COVID illness and not have to be, not even have to go to the hospital with any of the vaccines that we have. So they're all really effective. So I think, but they weren't compared head to head. So it's really hard to compare them. We're just comparing, their results sort of like, oh, well, one was 70%, one was 94, but they weren't really compared at the same time frame and in the same study in a blinded fashion. So it's hard to really compare those results.
Yeah, and different times and variants and things like that. A lot of changes between one month to the next in terms of the pandemic, for sure. You can probably see there's an anonymous person that put in a question about being immune compromised because of another treatment versus immune compromised. Your immune compromised state is the problem from other immune deficiency, if that makes sense. So do doctors differentiate? And do you need immunocompromised volunteers for studies, I presume?
So there are studies that are going on for immunocompromised people, and they were not included in the main phase 3 studies of any of these vaccines that we have. So definitely, as far as the vaccine's concerned, we don't differentiate. We want you to get the vaccine, any of the vaccines that are approved here, but in terms of doing studies and trying to understand that better, we do need volunteers. So I know Dr. Rogers and Dr. Pharmakiotis in the Infectious Disease Division are looking at studies for those types of patients and seeing if you've already gotten 2 Pfizers or 2 Modernas, would a third dose of something help you make some antibodies? It may or may not work, but the only way to find out is through studies.
There's a funny question I have that I've never quite gotten my head completely around. Is speaking of immune compromise, why is it so hard to make a vaccine against HIV?
I know. So guess what they're working on now? They're working on doing the messenger RNA-based HIV vaccine. It's been so challenging. They've made some really complicated vaccines to try to address it. It just hasn't been as simple as addressing the spike protein. A lot of it we say is because the HIV virus mutates so much that even within one person, it's mutating all the time. So it could be that.
So a couple more questions popped up. You can see George Petrovus put in, will an mRNA vaccine be available for flu by itself or in combination with COVID before flu season begins? Any word on combo vaccines?
There are combo vaccines being tested. Yeah.
Good. And then Edna had a question about severe psoriasis and whether they should get the shot. Do you know if that
still get the shot?
Yeah, I think that's a good idea. Probably all the more reason why you'd want to get it. Because the last thing you'd want to do is get sick on top of your psoriasis.
Yeah.
Awesome. I was going to ask you to speak a little bit about kind of FDA, the emergency use authorization versus full FDA approval and biological licensing and all the BLA, the alphabet soup of FDA approval, and just your, not necessarily predictions, but will, when one of these vaccines flips from EUA to being more fully FDA approved, how will that impact kind of what our decisions are or what the studies do? How will that affect the process, or will it have any impact on regular folks that aren't scientists on a day-to-day basis?
I think it won't really change a lot of people. The main area I think what's going to change is for employers, that they'll feel more secure in mandating the vaccine, or that'll take away one reason why people might be hesitant. So, we've seen the FDA approve remdesivir pretty quickly, went from EUA to full approval. So, so I'm hoping that they'll do it soon and not wait too long. It'll, you know, for me, it doesn't change anything. I consider the EUA approval to be, you know, fantastic and good enough to do what we need to do in a pandemic. But then they should do the full FDA approval as soon as they can.
I can imagine just, you know, as my understanding of studying things in correlation versus causation and all those things we tend to look at, you know, we would see tons of people randomly that would be diagnosed with things like TTP or cardiomyopathy, sometimes even in the wake of viral illnesses, not even related to vaccines. But, you know, once you give out a couple 100 million or a billion plus vaccines globally, I can imagine that when people come up with rare diseases that they might have come up with otherwise, now you've got a huge group of people that can look backwards in time and say, aha, I just got the vaccine, so therefore there must be some causation. Hunter, do you have any thoughts on how do you pick out what's the signal to the noise?
Right, so they definitely look at the background rate, what they would expect to see for those conditions. And that thrombocytopenic, thrombotic, the TTS, or they also call it the cerebrovenous thrombosis, or CVST. Yeah. Those are pretty rare. Only a couple of cases per year happen. So they do compare to the background rate. And, you know, if they only saw one or two, they might say, okay, it's probably not related to the vaccine, but they saw a little bit more than would be expected. So they definitely compare it to the background expectation.
Yeah, I think that makes a ton of sense. And it's good to, I think, to look at those numbers and take in consideration the background, because I think it would be easy for any one of us to have something funky happen and then look back in time. And sure enough, the vaccine is going to be in our history for the vast majority of us. So it can be pretty easy to draw conclusions, which may or may not actually be right. So.
And that's why the reporting is so important. So there are two ways to report. Like when we got the vaccines, we were told to sign up for VSafe, where they send you periodic questions by text. And then if something were to happen, you would go on the VAERS website. So VAERS, and anybody can go on the VAERS website and report a side effect that they think could be related. Doesn't matter if you know, how sure you are, just report it. It's fine. You know, it goes into a big database and they look at all the events that are happening. And then if multiple events happen, then they'll start to investigate more closely. But it's pretty, you know, it's really encouraged that if there is a side effect that somebody thinks that they may have had, to report it by the VAERS system, VAERS.
Well, I know we both share kind of an interest in public health. And so I can tell you that from my understanding, when you look at any treatment that we do, medications or otherwise, and you look at what are the risks versus what are the potential benefits, and where did that fall, numbers needed to treat, and all this statistical slicing and dicing, the one that seems to always come up above and beyond in terms of benefits far outweighing the risks or harms is vaccines over and over again. And so, you know, I think the more we can get the word out, the better. And I certainly think that, you know, educating people about the potential risks and helping them make the right decisions for themselves is a really key approach. Certainly I'm passionate about as well, because, you know, I think at the end of the day, each person's individual risk of exposure, risk of illness, and then potential risk for allergic reactions or side effects or things like that. Those are not necessarily easy and obvious questions, but for the overwhelming majority of us, I think it's kind of a no-brainer. And so I was joking with you as we were starting to log on that I've got a couple of kids under 12, and we were really excited to get them enrolled in some of the clinical trials to give them at least a shot of getting a shot. Yeah. And so we're pretty excited about it. So I would encourage anyone here, if you have yourself or friends or family that have some hesitation about getting the vaccine, or if you know people that do, what would you recommend? Talk to their primary care doctor? What resources would you?
I think, you know, talking to their primary care doctor is really great, whoever that is. And they can always join our study if they're 18 to 29. I was talking to one of my patients recently, and his whole family got vaccinated except for the son, who's 20 years old. And I guess, you know, he just didn't feel like doing it. I don't know, you know, so I think I'm hoping that he would consider joining our study, because then we can have a discussion about it and what group does he want to be in the study. You can actually be in a vaccine decliner group.
Oh, that's
So
interesting. No, that's a good
yeah,
point.
so it'll be interesting. I think it's concerning when like whole families decide not to get it. And, I think at the beginning, when we first started getting the vaccine, we were all excited because if we got the vaccine, we would protect our parents from getting ill. I think that was a big, big concern. People bringing home the virus to their older relatives. And then when the older relatives got vaccinated, that made us feel a whole lot better. Now the people most at risk of dying got the vaccine. And so, I think we're doing it not just for ourselves, but for all of humanity. So I think that's another good reason. And, we just got to tap into some of the reasons why people, would get motivated to do this.
Yeah, I agree. I know in our ethics conversation, we talked about us as healthcare workers, we're even more obligated because now we encounter people who might be at risk or haven't gotten the vaccine. And God forbid, we're one of those people that's asymptomatic and we might give it to them. That could have serious consequences to their health. And so we owe it to the people we take care of to protect them. So it does create some interesting conversations when you're talking about healthcare workers.
Yeah, like we do with the flu shot. So we're protecting our patients.
One last one, any words of advice? I've heard some pregnant moms saying, I want to get the shot so I can give a little bit of protection to my newborn baby. I've heard some that are a little nervous. So I don't know what to do if I'm pregnant or I'm breastfeeding. I know you talked a little bit about it at the town hall and had some great points, but any last minute stuff for?
Yeah, no, definitely, pregnant women and breastfeeding women can get the vaccine. So the pregnant women should get the vaccine because if they got COVID, it could be worse for them. And then they're carrying the baby. So that's like, protect yourself and your baby by getting the vaccine while you're pregnant. If you're breastfeeding, it's even better because, you're no longer pregnant and the baby will get the benefit of some extra antibodies that you'll pass along in the breast milk. So that's very nice. I remember years ago, I actually got the flu while I was pregnant. At the time, the flu vaccine was not recommended for pregnant women, so I didn't get it. And maybe a year or two later, they started recommending it. But I had a terrible flu illness. Then I got pneumococcal pneumonia. So it was just not good. So I see this COVID as very similar for pregnant women. We just don't want to get sick. And we did see we had some patients at Rhode Island who were very late in their pregnancy who got COVID. And one woman, she got remdesivir in the study, but she was intubated for a month. She didn't see her newborn baby for a month. They really did an emergency C-section. And thankfully she recovered and she got to see the baby. But can you imagine, it was just like heartbreaking. So if we can avoid that, let's do it. And we've got the vaccine now.
That's definitely a pretty compelling argument. I remember that case and a few other cases like that made it into the news where, moms would have C-sections and then they would be rolling out of the hospital. And that was the first time they'd see their baby because we couldn't have babies be visitors in the hospital for lots of reasons. So,
right.
Yeah. Well, I think, certainly from my mind, typically in medicine, what's good for mom is good for baby is a good general principle. And I think that certainly applies here. And if you think about it, if your baby's too young to get vaccinated yet, this is really kind of one of the few opportunities you have to help protect your baby. So if that's not motivating force enough, being a parent of little kids, if I could do something to help keep my kids a little bit safer and it's something you're going to do to me, so I get all the risk and they get all the benefit, again, line me up. I'd be willing to take even a lot more risk, and to know that the risk is vanishingly small is even more reassuring. So that's awesome. Excellent. Well, I really appreciate you taking the time to do this.
Sure.
Thank you for going through this. More importantly, thank you for all that you do for Lifespan, for Brown, for the students, for the doctors within Lifespan and with the Department of Health, for the state of Rhode Island, really for this whole region. You have a huge impact on what goes on around here. So we're very fortunate to have your expertise, and your science and research will have impact globally. So very rare we get a chance to sit down and talk with somebody who's really making a dent in the universe, quite literally. So it's very exciting for me to be able to chat with you, and thank you for all the hard work that you do to try to move this forward.
Glad to do it. Thanks for the conversation.
Absolutely. And for those that hung on to the end, we will get set up with our next virtual community lecture series, hopefully in the next month or two, if we get another rock star presenter. I've got a few up my sleeves. So otherwise, we will sign off. I wish everyone a great night. Thank you for joining. And thank you again, Dr. Tashima, for taking the time. Much appreciated. Have a great night.
You too.